It is a great pleasure to introduce our next speaker. Lucien Engelen is a fantastic innovator, the kind of visionary that is transforming healthcare and healthcare institutions from within. From Nijmegen in the Netherlands, the Nijmegen Health Center was facing dire situations and needed transformation. Lucien has been mandated to introduce innovation and the practice of innovation within this large university health center in the Netherlands. With REshape, the center, they are transforming the way to deliver healthcare, transforming the way to operate a health center in the Netherlands, and they are showing the rest of the world new ways and new ideas on how to do so. So it is a great pleasure to welcome Lucien Engelen.
Well, thank you very much, Luc. It's great to see my brother from another mother again, and then a bit far away. So thank you for allowing me to come to you in a digital form. As you might know, we've also set stage for a nationwide Hacking Health Hackathon last year and are doing exactly the same this year, already with 5 academic medical institutions, assisted living centers, and all kinds of other very interesting healthcare institutions together with patients, family, and informal care, because that's our main tagline, that we want to introduce new ways to deliver health and to promote health, incorporating technology and, of course, also from the get-go, patients, family, and informal care. So let me switch to my screen here for a second to share some of the slides that I prepared for you. So what we're trying to do actually is that we try to make sure that this climate change that is happening at present in healthcare, where a lot of people see that technology is really changing the landscape, is completely being ignored. And about neglect and ignoration, we've also seen in terms of the European Union and Britain, of course, and also recently in the US. And as some of you might know, we had our elections 2 days ago, and I was very curious when I woke up whether or not it still will be my country, which luckily enough it is. 82% of all the people showed up to give their vote and make the Netherlands a better place. The thing, however, is that if we see what technology can do to promote health and healthcare as such, there's a kind of neglect. We tend to not see what is happening.
Just to let you know, we cannot.
So, like I said, there's a kind of neglection in terms of healthcare with all the technology that's present that we can use and are still not using in everyday society. While software is eating the world in every aspect of our society, a digital strategy still is needed. And I see a lot of healthcare institutions that are igniting a digital strategy now. So I would say welcome in 2012, because it will take you like 5 to 6 years before anything really starts moving in that aspect. When I drive to my university medical hospital in the morning, what I see, and a couple of weeks ago was surpassed by this great Tesla car at the left side, at the same moment and time when at the right-hand side I surpassed a gas station. And I thought, oh my God, what are we going to do with all those gas stations when everybody starts driving electrically? And the answer to the business model of gas stations is that they start selling quote unquote healthy food, as you can see in this slide. And somewhere in the middle, you can still pay for your gasoline or other things into it. We all know that driving at one point in time will be prohibited for people. My youngest son, 18 years of age, just recently had his driver's license, and he will share with his kids that at one point in his time in life, he had to obtain a driver's license. And also, by that time, there will be no road marks and road signs anymore, and at the right-hand side, these gas stations will stop to occur. Even Apple is working on a different model, surpassing the phone, surpassing the tablet and the laptop, And they are fiercely working on augmented reality, virtual reality, and mixed reality as also their new business model. And even as at least our Canadian friends know that there is an X Prize where one of the Canadian companies is contesting for the $10 million prize by bringing in technology that fits a doctor in a small box with supposedly 19 diagnoses to be made to do from the comfort of your own home, and some of them already have been medical validated. But still, we tend to use and ask patients into the clinic to take, for instance, an EKG, while also smartphones with a very small strip at the back end of it are perfectly able to do the same, not as high fidelity as on a bench with 12 leads, but still is possible. And now are changing into even bands combined with your smartwatch from Apple, for instance. A couple of months ago, I was given this business card, supposedly also able to run an EKG, which of course is phony. All the rest of the stuff is validated, FDA approved, CE check marks. But you can trust me that within a year from now, such business cards will tend to occur as well. And we are using small patches, like the one that you can see in this picture, that you could connect to your chest, measuring 4 to 5 days, 9 vital signs remotely: respiration rate, heart rate, stress level, skin temperature, and making also a 2-lead EKG remotely, sending the information into the hospital. So we're now starting to live in an era where we'll go from measurement into continuously measurement based on all kinds of new technology. Technology, by the way, that also brings in very interesting discussions. The graph that I'm showing you right here, where the red line is the glucose level of somebody with diabetes type 1, and the blue line is the heart rate variability. So at one of our REshape breakfasts, we said, what would happen if we would combine those two measurements? And we think, we're validating this right now as we speak, we think that this shows that 30 minutes prior to somebody stepping into a hypo, we can see this happening based on their heart rate variability. If that is true, that would be a game changer for people with diabetes. No longer have to prick into their body and stuff like that, and more on the predictional aspect of it. Same is also true when combining just data, just information in an app, as we did together with Philips, and that's what this slide is showing. There's 14,000 apps for people with diabetes out there. So we combined some of those, split it, and scattered stuff into one app. And this is a very preliminary result that I want to show with you, that only based on giving correct information timely in the hands of patients, we see that a bit lower of the HbA1c is occurring, less worries for the patient, no increase of hypos, more insights, and a bit more education needed as well. So we also see web-based innovations as interventions. And that also counts for instance, these little chaps, which are the 2 small earbuds that I'm wearing already for 2 years, completely wireless, charging, connected, able to listen to my music, make a phone call together with Luke prior to it, but also measuring my heart rate, oxygenation level, and all kinds of other interesting metrics. 128 sensors incorporated in these little devices. That is actually a Kickstarter campaign. So one could only wait until this goes mainstream, and I think the majority of you know already that Apple at September 9th introduced the Apple AirPods, also completely wireless, also high fidelity, without any sensors, at least that they disclosed to us. But in version 2 and 3, trust me, there will be tons of sensors incorporated in these things. And then you could send that data, for instance, into Apple's research kit, where you could create not only consent for patients, but also start processing these information and send that information directly, as in our case, into our electronic medical records. So no longer adding to as a separate step, no, integrated in the same workflow system that our professionals are working in. Using that data as well, for instance, and I often joke that Apple is becoming an academic medical center, to research on that. In one of the research that we've done on Parkinson's, where one of my colleagues, Bas Bloem, was incorporated, in 48 hours, we were able to include 18,000 patients. That's as much as all the academic medical centers in the Netherlands would reach within 5 years. So this has been done in 48 hours. So those things are really changing the equation. Also, one, two, five, excuse me for that, scroll back. Where we also see that to work with that research kit, we have to be able to code, which is not something that researchers and patients are able to do. So we created this platform that's called Reach, where with a drag and drop interface, you could create your own research as a patient union, or as researcher, and then crowdsource and crowdfund the data and the money for it. And everything that I shared up until now is true, but this slide is completely fabulated because I put in the Apple App Store a small app at the top level for it. And I think that is going to be true very shortly, that Apple or somebody else will submit additional digital healthcare insurance for 99 cents a month, where you 24/7 could reach out to a physician in Strasbourg that speaks Dutch, or in Singapore, or in Stockholm, or in Nijmegen. If only 5% of all the people owning an iPhone would do that, that would make up for a $1.8 billion market a year, just to give you a bit of a perspective on that. We're also testing on what could happen with the blockchain. Blockchain technology, I think the majority of you already know of. The thing that we've done in a proof of concept is that we've added the banking card together with the random reader to it, to give access to patients with the help of their banking card and a random reader as the authentication tool. Because in the Netherlands, 93% of all civilians are using that technology on a daily basis. So why use something differently? As I say, all that data needs to be processed. Companies like IBM with Dr. Watson and all kinds of other ones define multiple developments in healthcare at the very present time. Machine learning, deep learning, artificial intelligence not only are kind of hype words, but we're only in the front line of experiencing what is going to happen with it and what's possible. This is a book that's getting written right now. But also, and this is a slide that I've stolen from my friend Nicky Hexter from IBM Watson Health in the Netherlands. He says it's not a box that you can buy in terms of everything's in it. It's not still usable for the patient. It does not replace the professional and all kinds of things. So this is first generation technology that's getting into the healthcare arena. What could happen is the same as happened, for instance, to the New York Stock Exchange. In the mid-60s, as you can see at the left-hand side, 6,000 people were working over there. Still, 16 working stations on the main floor on the New York Stock Exchange, handling all the stocks and bonds for 79% of all of it. And still 6,000 people working there, but now they are keeping all those algorithms healthy, so in a completely different arena. And we think that the same will be true for healthcare. This is an ICU nurse in Phoenix, Arizona that I visited. With her workstation, she is supervising 250 ICU patients in the region for 17 hospitals. And that's exactly why we're now creating a huge telehealth and telemedicine center. Telehealth as into acute healthcare, the medicine aspect of it, and telehealth from the other side, based on all kinds of medical devices, consumer electronics that are blurring into this medical atmosphere. So what we see that like our own, the Netherlands, has created an ultrasound machine as big as and connected to a smartphone. We're now testing these things on the ambulances in the Netherlands to see whether or not comes in the next will be bringing this technology into the homes of people, together with all kinds of avatars and smart assistants that really would push the needle and push the envelope into giving authority and assistance to patients and citizens, actually. So if you see these things and step backwards a bit, you can see a clear pattern here. Things get small, things get cheaper, things get incorporated in consumer technology and actually are medical devices. From that, we see still, and that's the neglect and the climate change that I see, still are calling patients into our house that will come into our hospital burning fossil fuels, try to get into the hospital on the top level parking lot, finding that last spot that's free, rushing to their 10 a.m. appointment at the department, stepping up to the front desk 2 minutes earlier, and then the assistant would say, the doctor's running late. Please take a chair for a minute. And at the moment in time when you're being called in to the physician's office, that's where the clock starts ticking for the only 8-minute visit. Afterwards, again, starting to burn fossil fuels. So we really have to rethink our model here. A model where everyone is expecting that they can take their blood pressure in the comfort of their own home, completely scientifically validated. That we are using video conferences already reimbursed in the Netherlands that would make up, just to give you an idea on what we're doing at Radboud, if only 5% of all the outpatient visits would be done completely by video conference, that saves us as much as 200 parking lots a day. That's a whole parking garage a year that we're talking about. So trying to push these needles and giving patients the opportunity to test some of the vitals and the measurements in the comfort of their own home, also changing the medication that they need and submitting that to themselves in the comfort of their own home. So we really think that academical healthcare is going to shift into top clinical healthcare, from top clinical healthcare into the supermarket, and from the supermarket into the homes of people. But still, I do think that this is only halfway, hospital to home, because all of you in that room right now are not at home, are not at work, but each and every one of you might carry their own phone. That is the connection hub 24/7 at elbow reach to everything that's happening. So I really do think that we're going to see a shift from hospital to phone. And I would argue if the left-hand side is the hospital room of the future, or the right-hand side will be that. Walmart is wanting to become the #2 healthcare player in the US and is opening at a pace of 5 clinics per day in their retail clinics. And Virgin Care, the record company and the airliner, Richard Branson, recently won a £750 million contract agreement with the UK NHS. So these are completely different players, like Amazon, that has the ambition to start delivery, same-day delivery of medication. And I was able to present recently to the Belgian Association of Pharmacists that would say to me, well, Lucien, that's great, but they don't have any clue about pharmaceutical models. And I said, yeah, well, that's true, but that's why they hired 200 pharmacists already. That's the thing that we see right now. At the end of 2014, we've calculated that 70% of all the things that we're doing at the campus at Radboud, routines, no longer will be done at our campus by 2020. A shift between bricks and bits. And the thing is that the majority of the public opinion already is there. Because what I'm doing right now is people that already incorporate 14 people, 2% of them only think that within 10 years from now, healthcare will be delivered by a doctor. 10% in the hospitals, 20% at people's homes, and 70% all over the place. I reran that study, by the way, also in my Twitter account, just to have some extra check into it, and I got back exactly the same results. So this is where the shift is going to happen. In a world that's connected every day and every spot, we have to rethink the model. Even though we know that the number of people above 65 in the next 15 years will double, we will face the Rolling Stones generation actually are becoming submitted to elderly homes. They are using technology as the first wave, but the second wave is the Generation Y that's coming up. They are living in technology. And with all specific disease like obesity, diabetes, and mental health diseases, those two will be the majority of the healthcare consumers, as you might know. Going back and to explain the world in tweets, I think this is an interesting one. At top levels and left-hand side, all the devices that are now incorporated in one phone. And in the US, sometimes you can see somebody living in his own bubble with a virtual reality glass as in the middle. The most shocking one for me, however, is at the right-hand side, where the right-hand dog is a one-on-one clone by one hair of the other dog. For $15,000, 300 dogs get cloned in Korea as we speak a month. And how this would translate into human aspect, I don't know. What I do know is that, as Einstein said, we're still using old maps to explore new worlds. And we have to rethink those models. And that's why we said at Radboud we want to have a strategy that incorporates digital first and physical next. That's not to say that you no longer are welcome physically, of course. Yes, you are. But we want to, by default, also offer you if you want to use it, and if you can use it, a digital ally. And that's something that's new for us, of course, because a digital strategy is not translating what we do right now into digital. It's completely rethinking the model from the base up, because it's no longer about IP and org charge or capitalization. We really still think that the future will be something a bit like we've seen already, but it's completely different. It's different, for instance, from the aspect that healthcare is becoming globalized. And that's why we have to be curious about everything that's happening out there. That's why we set all kinds of interesting partnerships that we will work on, because other players than the ones we know still are going to play a big, fair role within healthcare. And that's also the reason why I ignited in 2015 the global network of healthcare innovation centers, and these are some of the the innovation centers worldwide that have joined us already. The thing, however, is, and maybe this is the most important slide of all, from our big friend Sarah Rigare from Sweden, who suffers from Parkinson's. The red spot in this graph at the top level is that 1 hour that she spends with her neurologist in the hospital. And the 8,765 other hours is she's on her own. So in everything that we do, we have to take into account the patient journey, of course. And also the journey of the institution, which is a bit smaller because the patient has a bigger span of it. And even have to look into the professional journey, which is even smaller. But the biggest one is the life journey of the patient. We have to take into account that these things really matter, and we have to know what other than the medical aspects come into play for patients. So as opposed to innovating for patients or on behalf of patients, we've started, patients included, to innovate 6 years ago in a REshape center together with patients, right from the get-go. And now we're heading to the next phase, where we would say, we'll give you the tools that we have developed already, and we step aside, we would watch what they are going to do with that. Which is an interesting new perspective. And for that, we've created the REshape European Center for Healthcare Design. So bear in mind, this is not the European Center, but because the difference between the United States and in Europe, and even within Europe, we have delivered separate and different healthcare systems, we have to get a hold on how this really comes into play. How this plays, for instance, together with the data. Still all kinds of data points that are separate islands and flocks of data that the patients have to collect. With all kinds of interesting combinations that have been made, we really created all kinds of ecosystems in healthcare. And why not share all the data with the patient themselves? They are the only one constant factor in everything of it. And within the boundaries of the elections, we're now really actually trying to get this up and running, that only the healthcare data for patients should become a constitutional right. If we're able to run that, and that most probably will not occur within the next 3 or 4 years, but we're fiercely working on that, that would be a game changer. Not only in terms of authority, but the patient now already is getting to collect more data themselves as we have as healthcare professionals. And we will be present when somebody gets sick. So we will have the opportunity to take a subscription on the data of patients as opposed to the other way around. So I'm encouraging our government to no longer pay healthcare and reimburse healthcare for institutions if they do not comply to the standards that we have. Still, there's a lot of discussion about terminology, about e-health and mHealth, and I coined iHealth in 2016. But actually, we should get rid of all those different silos. Basically, it's healthcare. It's just digital healthcare. And if we keep continuing to connect all those e-health solutions at the outer side of our healthcare model, it never will become an integral part of that. And that's what we have to solve. And that's also what patients expect us. On the other hand, if you look into, for instance, some spots in the US, and this is a picture of Bernard Tyson, our great friend from Kaiser Permanente, who's the CEO, they've got 11 million members in their system. And more than 50% of all the outpatient visits in 2015 have been done already electronically. 23 million e-visits occurred in 2016, and they say we no longer wait for the evidence. The evidence is that our patients are using it, they like it, and they have a great experience with it. And based on the evidence aspect, this is a graph that I've created with one of my researchers about e-health, mobile health, and digital health. And as you can see, that in 2015, the number of papers are going through the roof. And in 2016, we have some early results already. This is even going exponentially. That's not to say that every study is a positive one or a negative one. It's more that we see that there's an uptake into it. And we're now clearly facing the iPhone moment as shown in this little picture. At first, there's a bit of a disappointment. There's a bit of worries. We don't know about privacy and all kinds of things. And all of a sudden, we're facing that iPhone moment when things start to work and really come into play. So the thing we have to do is we have to dare to fail. And that's exactly as Luc shared already. That's exactly what we are able to do at Radboud University Medical Center in a small cell, that we are able to do these kind of things. The objective in the end of the day with all that technology is not to replace physicians or nurses or other workers in healthcare. We want to restore the power of the human touch, because all the administrative burden, for instance, and the routine stuff that we're doing is getting replaced by real human warm attention. We want to add to what I like to call, and I coined it, experience-driven healthcare. Of course, evidence-based, as opposed to evidence-based healthcare based on experience. We have to flip the coin, and that's exactly what patients expect from us. So wrapping up a bit, I think I shared a bit some of the stuff about how we think that healthcare is becoming delocalized. Stuff is going to happen in a different place. Healthcare will become democratized based on the data that gives a different level, equal level playing field for patients, family, and informal care together with their physicians and nurses. Healthcare is more and more becoming digital, and not only from an infrastructural standpoint of view, but also 1 minute prior to 10 a.m. something's not possible. And with the press statement that's announced at 10 a.m., all of a sudden, as a dermatologist, as an example, your world has changed by publishing an app that really does work in discriminating a mole on your hand. And the last D of my 4 Ds is about dollars. Huge investments on a global level are being made. Tens, hundreds of millions of dollars are being poured in infrastructure to harness data within healthcare. So to us, it's no longer about being the smartest one of all, like Darwin also already shared with us. It's more like, are you able to adapt to this new paradigm? And with that, I really want to encourage everybody, and also in the hackathon, be aware of the denial and neglect. Find the opportunities, find the chances, work on that, and let's prevent that this is healthcare as we see it in a couple of years from now, because we deny the opportunities that we have. With that, thank you for your attention already, and I would love to give the mic back to my dear friend Luc over there.
All right, thank you, Lucien. We'd love to see your face again. There you are.
I'm trying.
I'm sure we have many questions. Je suis certain qu'on a plusieurs questions dans l'audience ici. Alors, à vous.
Hello. I'm very surprised by everything that you were telling there. I'm questioning the human and psychological and social part of the healthcare, because if the data is only about digital and physical situations and not about how the psychological influenced it, then how do we professionals still work with human beings, and how do we get in touch with people? Because for me, it's basically the base of healthcare. And so we need, like, the second part of what you're saying is that we need to be formed as professional to take care of this human and social and psychological part of this disorder. And for now, medics are still formed to take care of physical disorders. So it's a big change of paradigm. It's more than just a digital change.
Absolutely. So thank you for your question, because it's spot on. And I would answer it from 3 perspectives, actually. One is that we, as professionals, are running a lot of routines on a daily aspect that also could be done if the patient wants and is able to in a digital form. Like I said, for instance, taking blood pressure, there's no actual reason anymore to not do that in the comfort of your own home. Actually, we know that taking the blood pressure in a medical institution raises the blood pressures by 20%, as we know. So that's the first part of it. We are doing things that are not tickling your intellect and also not the training that you have. That's one.
However, when you take your blood pressure 3 times a day, it gets very, like, you know, it can push you to feel anxiety as well, because then you will be checking physical parameters that are aren't usually something that you think about. So that can completely change the behavior you have every day with your health and the way your psychology is evolving with yourself. This is something we have to think about, because if we have to put data all the day into devices, then we will not be living, just enjoying our times and just thinking, oh my God, my blood pressure is different because I have an emotion. So what does it mean? Do I have a problem? You know?
Yeah, I completely understand. So what I'm saying is not that you should check your blood pressure 3 or 4 or 5 times a day. What I'm saying here is that we have to stop calling you in once every 4 weeks to take your blood pressure once and base all of our interventions on that one spot measurement. So if we're able to do that once a week in the comfort of your own home, or if needed, if there's a trend line in it that argues with it, to do it multiple times, that's what I mean. Second thing is that if that is the opportunity to do, we have more time to spend in the actual conversation together with patients. And that might change, as we also could do that in terms of a digital form, just like we're doing right now through video conference. That's not always applicable, but when we question the majority of our patients that we've did in all of our research, they say, I don't create great joy of coming to your hospital because I have to take a day off and all those things together with it. But sometimes I do need to sit at your desk and be able to look you in the eyes in a different form. But now there's no choice. And what I'm arguing and trying to bring in is that it's not an or question, it's and in my perspective. So the third question that you pose in terms of the psychological aspects, in terms of people starting to work and measuring everything they do and lose with that the joy of life, that's true. And that's a new balance that we have to find. On the other hand, there's a lot of patients that are completely worried about how they're doing, and now they only have once every 4 weeks an option to see how that works. And so there's again a more like a trade-off coming up in finding a new balance. And as I said, I think that we're writing this book while we're at there. It's new. We have to find also new evidence and new approaches for studies for it. And I think that's an interesting era that we live in for that.
Alors, on a d'autres questions. We have other questions here in the audience.
Good morning. Thank you for an enlightening presentation. I would like to ask a question relating to how do you view in the Netherlands privacy of patient information, as you spoke that it's going to be delocalized, so your information can be spread everywhere. In some countries in Europe, this can't happen because people want privacy. They don't want, I wouldn't like to know that if I go to a doctor, everybody knows this on WhatsApp or whatever. What is your view about that, please? Thank you.
Yeah, well, thanks for bringing up the privacy aspect. There's always somebody doing that, so thank you for that. That's a good thing. So I got a hybrid vision on that. If I talk to patients with a chronic condition, I clearly see that they have a different perspective than policymakers in our parliament. Because the last ones are trying to picture a society where there's such a thing like 100% privacy and security. And we all know that that's not the case. There always will be a hacker smarter than the smartest and best system. Having said that, I think that there is a new trade-off and balance coming up between comfort at one end and privacy at the other one. And what our approach in this is that we say it's you as a patient to choose. It's not me as a member of parliament or me as a director of an institution. It's you to choose. If you can and want to. If you say, well, that's for the doctor to decide, that's fine. And that's why I shared the slide where I say owning your own data should become a constitutional right. Secondly, we need to take care of privacy, of course. And everything that we've done at Radboud, trust me, it's completely compliant to every certification that we need. But we also see that patients do want their privacy, but are sharing it themselves on Facebook and different spots into it. So again, you're mentioning WhatsApp, completely agreed. That's, in our case, out of the order. But if the patient has the ability to be more flexible in it and to stop it instantaneously, that's where we get into a different control area for it.
Alors peut-être une dernière question. Ouais, ben peut-être, il y en a une ici. En attendant, moi j'en aurais une si tu, if I may, Lucien. You mentioned dollars. A lot of the people here wonder about the revenue model and the financing model. It's as if, yes, the future of healthcare with digital technologies will be less costly and of higher quality, but it seems that to get there, nobody's willing to invest the funding or to help the startups to that transformation.
Yeah. Well, Luke, you know my perspective on this. This is not different than every other intervention and invention and change in healthcare over the last centuries. If you want to do something new, always there will be a peak in terms of costs, and then we'll get an iterative process to do that. The thing, however, that's lacking within healthcare is that we tend to look only to the silo of healthcare. We're not looking into the societal benefits. Example, like I shared, the benefit of somebody not having to take a day off of his work to go and visit the doctor in the most of the studies that have been run is not taken into account. So the labor aspect is not. The aspect of polluting our planet is not taking into account. All the studies that we see right now are very narrow focus on that aspect. So what we see is that once we can prove and show that it is effective and it has its efficacy and people do want that better experience, that's where things come into play. So there's no difference, in my opinion, in terms of digital health innovation as in pharma. Let's be honest, only 1 out of 7 drugs that get created will hit the market. The other 6 ones are vanished, and we all pay for that as well. So my point here is there is no innovation without spending a couple of bucks of money prior to doing that. In the end of the day, digital health for us is one of the biggest promises. Why? If I, based on measuring your science over the course of the last 6 weeks, can prevent that you as a COPD patient gets into an exacerbation, that's not only preventing a lifetime event, but also preventing spending of enormous amounts of money. Those, however, is still tricky because in terms of how much we prevent in terms of money is not often taken into account because we have a fix-it system in healthcare as opposed to a prevent-it system.
One last question over here.
Okay. I can't hear anything.
Yeah, sorry. I'm very sorry, but I will ask my question in French, and if somebody could translate it, because
Je vous en prie.
It will be a little bit technical. Je trouve ça extrêmement intéressant et je vais en fait poser une question qui sera peut-être couplée avec la présentation de Sophia Genetics, notamment par rapport à l'étude qui a été présentée sur la fréquence cardiaque et les analyses de glycémie. Quand on voit la quantité de données cliniques simples qui peuvent être collectées avec tous ces systèmes sur un nombre de patients qui est théoriquement extrêmement important, qui pourrait encore être couplé avec des données de type Sophia Genetics qu'on pourrait imaginer dans le futur. Est-ce que ça existe déjà? Est-ce qu'il y a déjà eu des notions sur des analyses de ces groupes immenses de données, de découverte de maladies juste faites sur toutes ces analyses épidémiologiques qui vont être potentiellement énormes dans le futur.
Alors pour la traduction.
Luke, thanks very much already.
So Lucien, the question is, we've seen a presentation from Sophia Genetics that alluded to studies, epidemiologic studies related to cancer treatment and diabetes treatment, and there is a massive amount of epidemiologic studies on that end, and on the other now there's new massive banks of genetic data and genetic transformation. So the question is, has there been use of these massive set of data on the epidemiology side and on the actual clinical side made into relation with the genetic side for providing medical discoveries or other types of discoveries?
Okay. Well, bluntly and to be honest, not yet. We are in the midst of it. At present, there are 3 studies running at Radboud University Medical Center where we will follow a cohort of 500 people taking all kinds of data in, and that varies from their whole DNA profile into some measurements from their blood in terms of vital signs, in terms of activity levels that they have, and even in terms of what they're eating. So this is one of the first studies that has brought us, that I just said it in that perspective. And we're only just creating these opportunities because the majority of those technologies did not exist 2-3 years ago. So unfortunately, I have to say, this is new work. It's a new era. We will discover new opportunities and also new questions, because the ethical aspects on many of these new opportunities also are huge. So I sometimes get questions by people in the audience what their son or daughter should start to study. And I really, opposed to all other kinds of jobs, would say start studying ethics, because that will be the majority of the discussions that we will have once the technology brings us the opportunity to do almost everything.
So on these visionary words, merci infiniment. Thank you very much, Lucien. Thank you so much. Thank you for...
Thank you. Haks over to Radboud, and hope to see you soon, Luke.
Great, and thank you for being part of this movement. You are one of those visionary health hackers that inspires us all, and we're glad to be all working together to make healthcare better for everyone. Merci.